Thank you very much, Rachel. My name is Yves Dudekem. I'm a pediatric cardiac surgeon in Melbourne, and as you probably know, I've been quite involved in this Fontan research. So that's a slide I usually go through very quickly. It's the first slide of all scientific talks. It's the disclosure. And for once, I'll just spend a few seconds to explain you what it is. I have to disclose my involvement with a pharmaceutical company, and I'm involved with two pharmaceutical companies. I can give you a hint. If I am involved with a pharmaceutical company, if it's because of my expertise in the Fontan arena. And that's why I explain it to you, because the Fontan arena, that's you. All right? So what I'd like to make the point is that some people, and more in the medical community than in the patient community, are feeling uncomfortable to work with the industry. I'd like to insist on one thing, is that if you look at research that is done for you, 66%, 2/3 of the research in the US, and it's the same worldwide, is brought by the industry. That's the money that goes to research for new medication, new treatments. 25% following the area is provided by the government, and the rest, like 10 or so percent, is given by private donation, university, and so on. So yes, I'm involved with the industry, and I'm happy with it because it means it makes things progress. And for the first time in many, many years, the industry has been interested in your population. So there are trials now that are coming, and we involved with one, but there are many others, because they're finding out now that maybe medications may help you. So that was for disclosure. I'll get back to this, and I think that I'd just like to make you think about that. I've been always inspired by this say. I think it was a great quote. And I think the things that the take-home message is that this day should be about empowerment, and I think that you should follow the example of Rachel and find out for you what you can do for your Fontan, and I think this talk will give you a few ideas. I'll briefly summarize where we've been and what's ahead of us. So the Fontan Registry started in about 2008. We had our first seminal paper in 2014. That's 6 years of waiting for heart surgeons. We're not known for a very long patient, so that was a very long time for me. More than 1,500 patients. 22 patients only refused to participate, and usually that's a problem of comprehension. They don't understand exactly what's going on. So I'm very proud of this achievement. It's the largest database in the world of Fontan people, and this way we're leading this research worldwide. If you want to know about what we're doing, please go on the website. We're going to soon have the 2017 report. It takes always a few months to gather all the letters from the follow-up. You've seen that slide from Gavin. This population is growing and growing. It's going to double within 20 years. And every year we publish the results of what we have. With 36 years of follow-up now, have the longest follow-up. Don't be afraid about the figures. The thing is that we have demonstrated, that's one of the achievements of the registry, that you guys, the Fontan people, are living way longer than anybody have expected. And I think that we in this era where some people, like me, tend to say, our challenge is to have you living as long and as well as any one of us, like me. So that's our goal, that's our target, and I think the numbers we have are getting to there. So we've done a lot of retrospective studies, and I'll start with that. Then we get into cross-sectional study and trials, and I'll explain these words. Retrospective studies, that means that we look at all the data we can gather in the files, and we look at the numbers, and we crunch the numbers to have an understanding of what's going on and solve questions. And so I'll give you just a few examples. We calculated recently more than 45 papers, done article, journal, research, done on the Fontan Registry. The biggest one is this one. That's what put us on the map, is just defining the outcomes. And we called it redefining expectation because before that manuscript, there was a lot of people who were saying, oh, it's terrible and it's horrible, what are you going to do? And that set up the marks to say, hey, it's not bad. It's actually working quite well. And we've got 2, 3, 4 decades, and we now have the first patients getting into the 5th decade, and we have a handful of patients above 60 years of age who were operated later in life in Australia and New Zealand. So fast heart rate is a problem, something that we have studied. So we look at when did that happen. We're trying to investigate why it happens. We just have the characterization of how often it happens. That's what we're getting there. A lot more work to be doing there. And we're doing things that seem to be odd and remote and not as interesting. We do health economic studies. That study actually was looking at how much it costs in terms of what money the government pay in hospital. So whenever you go into a pediatric hospital, how much having a Fontan costs. And so we've put a cost on it, and it varies between $300,000 and $500,000, which we expected. But the important thing is that by doing this research, what we're looking at is what is costing money. And yes, more than half of the costs are for cardiac reasons, but a lot of it is for non-cardiac reasons. So we were surprised to see that the non-cardiac reason, the higher costs for Fontan patient in the hospital was dentistry. So dentistry is an issue. So they have more problems with teeth than others, and it sounds like a stupid thing. So we're going to talk about it this afternoon, but that's something we can work on. You talk to the head of the dentistry, he said, yeah, we should see them at 2 years of age instead of 4 years of age, like all the other kids. So you see, we do these health economic studies, and it brings something to the patient. So the more recent one, I have no slides for it because it's just new. We looked at inpatient costs in the adults, and we showed that actually the survival seemed to be better if you're regularly followed in the hospital by adult cardiologists than if you're not followed. It's obvious, but it's not that obvious. There's only one paper, one research in literature that proved that in congenital heart disease. And we, at the time when Lisa will probably talk about that, we're doing a congenital heart disease action plan. So the government is for the first time interested in congenital heart disease. If you can tell them, we're doing better, it's cheaper if the people are well followed, then we put that in place. We do not have enough adult cardiologists to look after you, so we have to build that up. Also, we've seen that half of the cost of care in the adults is non-cardiac. So it's crying for having multidisciplinary clinic. We should have hepatologists, psychologists at the same time, and we're just seeing a cardiologist. And so we've put out a call for getting Medicare data. And we have, thank you, the answer for 144 patients, but very few of the adults. You've heard about these things with the minister trying to get, this health data system online, and there's a lot of talk in the journals about how it's a breach of privacy and you're going to lose your data. I have biased view, but all I'm doing is working on big data. I do think that the population which benefit the most for getting a lot of data is you. The more data we have on you, the better it is for you. And so if we can come to the minister and say, these are the costs of treating this patient, and we can decrease it by so much by doing this and that, that's the benefit. So I think we still have a way to participate in that research by, provide linkage to Medicare, so we get an idea of how much it costs you to have a Fontan, how much you're paying into pharmacy, into GPs. And if we know that, then maybe we'll have access to the NDIS, so the National Disability Insurance Scheme, for which you're not candidate to the present time. But if we get this data, we can make our point for that. So that seems remote from just medical research, but it concerns you highly. So everybody is very impressed in the world, and we've made a paper about it, of our involvement with you as a community. I think that's a unique setup, and we've made a paper of that and see the multiple interactions through the Facebook, the newsletter, and it's a bilateral communication. I'll try to be a bit more active on the Facebook page. I don't have enough time to put some posts, but I think that there should be more doctors posting on the Fontan Registry. So we've done looking back at the data that were in our hands already. We dig into that, and now we've been to cross-sectional study. Cross-sectional study is we call you back at one point in time, and we scrutinize. We've looked at everything in detail: liver, kidneys, brain. And we've got the first paper now from the liver and kidney diseases, and we know that when you have a Fontan, Andrew explained that, you're living with higher pressure in the veins. What's meaning having higher pressure in the veins? The example I give is, imagine you've played that as a kid, you're hanging head down with your feet up, and you wait a few minutes. So that gives you a higher pressure in your head. That's what happens in your lower part of your body. So you can feel the sensation of having a higher pressure in the veins. That's what the Fontan circulation does in some way to your liver and kidneys. You increase your venous pressure by 4 or 5 times, and so it has an impact. You have more scar tissue, fibrosis in the liver, and you have things that are different in the kidneys. Our conclusion after that was that, yes, there are changes, but after 2 decades, for the first 2 decades seems reassuring. We really need to follow that, and there are some cases of bad outcomes. The worst possible outcomes is having a lot of scar tissue and having a liver cancer. And people get very excited. You look in the internet, the people get excited about that, but the reality is the numbers are very, very, very little. So, but we have to observe that, and that's why the registry is the best tool to see, to catch up with that on real time. So we've done cardiac exercise, MRI, brain MRI. We've made a more sophisticated investigation, and I'll give some other data in one of the next talk. And now we're in the trial phases. And trials, AJ will talk about that later on. That's the top of the science. That's how you decide how to treat people. And AJ will give you a lot of details about that. So how can we improve your life? What are the technical advances? Remind you, I'm a surgeon, and so I'll see the things on a certain angle, obviously, which will not be maybe cardiologist or patient's advocate point of view. I'm very, very excited. The things that is my next crusade is the optimization of the Fontan circuit, and I'll explain you that. We know that in the Fontan circulation, the main things is having nice, harmonious flow with no impediment in the flow, because there's no pump, so it has to flow very nicely into the lungs on both sides. We've looked in another research at the rate of reoperation, not published yet, it's brand new as well, the rate of reoperation, and it's extremely small. We don't reoperate you once you had a Fontan. I've written 50 times that the Fontan is the last in a series of operations for patients with single ventricle. I think that might change, and that's what I'm working on. Let me explain you. You gotta, if you buy a $15,000 Toyota or cheap car, they look at every angle of the car with lasers and super computer, make sure that everything is perfect. You get your, super nice car, and then you're driving it for a month, and then they want to have it back just to check that everything is fine, and for free, and 3 months again. We do a Fontan operation. It's absolutely perfect. Like I do, what I do is always perfect, and off you go, and we never touch you again. So we looked at the pulmonary arteries. 2.5% of the whole group had something done on the pulmonary arteries by catheter or by surgery after Fontan in the whole of Australia and New Zealand. That would mean that 97% of the pulmonary arteries are fine. We know it's not fine. We can increase the size of these lung arteries by catheter, by blowing them up. The Fontan circuit, we have 1% of reoperation on a Fontan circuit. Of course, there's a little kink and bump and something, and so we can do things about that. But it's very difficult to prove that by doing something that has a risk, you're doing something better. Let me show you another example. So we've looked recently at a valve. The things that we found out is that if you have a common AV valve, so the heart is really not separated, we call it unbalanced AV, so the valve may leak with time. If you have a tricuspid valve, we're analyzing a little bit more. This data, again, this valve may start leaking with time. These are not large leaks, so these are level of leaks for which we would not operate in an adult with 2 pumping chambers. But with it impacts the Fontan circulation more than if you have 2 ventricles, and we've demonstrated that. These are difficult reoperations. You know, this needs surgery. It's difficult surgery. Then, you know, they're struggling. I've operated one for that reason just 2 weeks ago, and God knows if we had trouble. So it's not something you go lightly into, but that's something we're going to have to think about. And it's not a bad news, it's a good news. It means there's some things that we can do to improve the Fontan circulation. But it may need some extra work, and it may need some extra surgery. Arrhythmia is a complete black box. We just seeing the tip of the icebergs. So we're planning, and again, we need to work with the industry for that. There are tiny material that allows to record your heart for 3 years continuously, and we can even consult it at a distance and check whatever problems we are. And I think that's something that we will offer for you to participate and record your heart rate for 3 years to see what happens and what's exactly in. We just see right now when the people have complaints, and by chance we capture the bad heart rate just at the day of the year when you are with your cardiologist. So that's not enough. We need to know about the 364 other days. Exercise, there's going to be a lot of talk about exercise, and that's the one thing really that we're leading the field in Australia, and that's the talk that you need to listen to. I'll just give you a hint, because I've checked the other slides. I don't think that's in. So we've checked other, you know, everybody says that if you have a Fontan, you have 2/3 of the predicted exercise capacity. By doing exercise, you may be able to change that. I think that if you have a Fontan, that's your desktop office. You should be working non-stop. You have that slide? You don't have that slide. Oh, shit, okay. And I'm always pleased to introduce Victoria. She's a golden girl. She had a Fontan at 2 years of age, actually. And she's a surgical registrar, so she's training in surgery, general surgery. That means that she's able to stand up for the whole night. And if you have a Fontan circulation, you know what that means. So she's putting elastic stocking, as you should if you're standing up for most of the days. But she's able to work all day, stand up all night, and still be functioning with a Fontan circulation. She's got a secret. Whatever number of hours she slept, 1.5 hours of heavy exercise training 3 times a week. 1.5 hours, whatever condition there is. Pulmonary vasodilator, so these are the trials that the companies are trying. We know that with time, the lung arteries may not be as stretched as if you have a pulse into it, so they kind of shrinking slowly. If you dilate with drugs, you may have an improvement. The early results seem that you have an improvement. And the big question now is, maybe we should put everybody on it for the lifetime. And the company are ready to help. They're making about $35,000 per year per patient, so we can understand why they're ready to help. But that's a big question. And if you have a lot more patients doing it, the price will decrease, and so that's one of the things that needs to be studied. I'll spend a little bit more time about artificial hearts because that is the reason why I'm here today. It's been 20 years I've been working on the topic and willing to find artificial heart solution for Fontan circulation. Heart transplantation, we're not going to have enough hearts. There's too many of you. It's not going to be a solution for everybody. We have so far transplanted only 2.5% of the Fontan population of Australia, so it's a very small numbers. We should probably have transplanted 4% of them, so that's another thing. So we're going to increase the numbers, but not to the point that everybody's going to have a heart transplantation, not a practical solution. So we had some success with artificial hearts. I think we had the first success of a patient supported for 1 year, a few years ago, but it's still very, very difficult. The results are not good at this stage, and it's still the Everest of the specialty. So you can do a few things. So you can, on the left side, you can take the pumping heart chambers and pull the blood into and push it into the aorta. Or you can, you're missing a pump, you're missing a heart chambers that push the blood into the lungs, and that's one thing you can do. Or you can replace the both chamber and do a total artificial heart. So, and these things have all been tried with various success, and we've published our results about that. I think the thing that is the most exciting now is the people have used the device that's used for adults, okay? And so what they do, look at that. That's clearly an adult size. That's 3 years old that they've implanted with this adult device. Looks crazy. I mean, the guy, sorry for the saying that in this way, but the guy who done that had balls. I can tell you, because sorry. The big ovaries. Yeah, it's actually a guy. Sorry. But anyway, it worked well. So they have patients supported for more than a year, and that's a big advance. And we're starting to understand. This is the device, instead of pumping, it's actually sucking continuously, and that works better for the Fontan circulation. So we found that out. And so we're starting to have options. The people, the other options to just putting a right heart, replacing the missing bits of the heart, has been done successfully. There's one case report only, but it proves the concept. And the concept is valid because the heart is pumping. The strength of the heart is good enough in half of the patients that either die or have a heart transplantation. So that's not the issue. The heart that you have is pumping. We just need something to push through the lungs. So it's feasible. And that's what Mark Rodefeld has done. For those who have been before in education, I've shown this slide before. He's trying to build a device in the shape of a cross that is specifically made for the Fontan circulation. I'm in close contact with the guy. He's got the first machine on a bench, so it's in tube, so it's running now. So the next step we'll be trying in animals. So it is progressing, very slowly, but it's progressing. I wanted to find something else, and I thought maybe we can find other options, because all the devices we have, they're basically propeller in a tube. So you have a propeller and you have one directional flow. It's difficult to have a cross design like in a Fontan. So I thought, could we use what we have on the market? And I hypothesized that if you put something, if you push the blood only in the IVC, because most of the problem is in the inferior part of the body, liver, kidneys, it's all, the brain is not an issue in terms of venous pressure. So if you decrease the venous pressure in the lower part of the body, maybe actually it will go more to the lungs than backwards into the vein to the upper part of the body. And so maybe we could decrease the pressure here by having just a limited increase in pressure in the top part of the body. And so I went to do that in animals in Belgium. They have the only animal model where they can maintain animals for several weeks. They're the only one who is successful right now in the world to do that. And it's fine because it's close to my mother place as well, so it was convenient. And so we did that in the animals. So we construct a kind of Fontan, and we put a pump here just to see if we pump blood from the lower part of the body, and we even put a banding to see if it was in bad situation with very poor lungs, and it works. So we double the flow by having a minimal increase of the pulmonary the pressure into the upper part of the body. And so I'll briefly try to show you. I cannot advance that actually. It's maybe 1 or 2 minutes, so I'll eat up my discussion time. But so they have made this device for introduction into the groin arteries to help people with failing hearts, but not replacing all the job of the heart, but just helping out by giving a little bit of extra flow. And the way they designed it, they thought about the Fontan circulation as well. So they're now doing their first clinical implant. It's a very small catheter that is introduced in a descending aorta, but you could very well introduce it into the jugular vein and bring it down into the little Fontan conduit in the Gore-Tex conduit. And the beauty of it is that you can put percutaneously, so you don't have to have a big operation. You can put it through the vein, through the skin. And the design of it is that once you put it in, you can even remove it. So the concept we could have is that the patient comes really, really sick. We put a little machine here. We increase the blood flow. and then the patient gets better, we can take it out and get to other options. And then, we'll do what we call, bridge to heart transplantation. So just to show you that's new, I hope they're going to be successful and it's going to be in clinical use. We're discussing to try that in the animal model that we discussed. And if you can call the company to tell them that it's very important, then and it looks like I'm joking, but I'm actually serious. So the ultimate solution may be an artificial heart. We have now an international collaboration. So we met in Bordeaux just a year before the death of Dr. Francis Fontan. And we are a group of all the international experts are gathered together into an initiative, and we want to build an International Fontan Registry to improve the outcomes. Why do we need to have an international registry? Where we need more data. We need more data to build up population-based data in the world and evaluate the size of the population. We want to know why the people are failing. It's been almost 60 years we do that, and we still, 50 years, and we still don't know why the people get in trouble. We want to find out for the liver disease, we need to find out on time what's happening to the liver. Can we do something about it? And we need to find the time course. We don't know exactly how much problem it gives and at what time it will give problems. We need a scoring. We need to have a score where, the same way that in heart failure, you can be graded between 0 and 10. We need to grade you how well you're doing between 0 and 10 to find out. Then we do an intervention and we see what stage you're at afterwards. Then we need to facilitate research projects. The only trials that we have had so far had gathered, there's only less than 5 research that have gathered more than a dozen patients. So we need more patients together to do more research. We need to build a cohort of patients because a lot of the questions we ask, we don't have the answer in a year or two. We need 15 years. And for that, we need to have them in a registry and follow people for 15 years. Pulmonary vasodilator, we're doing interesting trials, but the real answer is you put them on pulmonary vasodilator, these new drugs, and we wait for 15 years. And so we need registry to do this type of work. And then there's a thing that is interesting is that if you have a Fontan in Australia, actually, between you and me, you're lucky. Because if you have one in the US, they're not the same. I don't know what they do differently, but they're not the same. And the one in Birmingham, and the same, quite similar to those here. And, you go in different places in the world, and they're not the same. So people do things differently. If we analyze the differences, we're going to find out things that will improve everybody. Next stage is we want to go to a single ventricle registry. We want to look at events from before birth, as soon as we have the diagnosis. That was our goal since the beginning, but we had to start with the Fontan registry because it was a shorter task. And we want to look at not only, survival, we want to see psychological well-being, exercise capacity, and for the whole of the lifetime. So we're going to talk a lot between all the experts here. We'll have a meeting tomorrow, and that's what we're going to discuss about. So finally, I would say, like Rachel has done advocacy, you can do something for yourself. We, doctor, we have to do something. So we have to give you good Fontan circuit, good pulmonary artery, valves that are not leaking. That's our job. That's something that we can try to improve, but you have to do something. So if you have to be active, so you have to be a voice, you have to be heard. I still met some medical students yesterday who did not know what was a Fontan. Everybody has to know. So you, as important as cystic fibrosis in terms of number, so the people have to know. If you have not participated to a trial or to a study or something, you are not doing your job. You have to help us to do the research, to do the work. And if you don't want to participate in research, then you can be an advocate, talk to your health representative, politicians. There are things you can do. Thank you very much.